Objectives today will be, again, understanding the impact of walking as a disability and what to look for. We're going to talk about appropriate medical evaluation from a neurologist perspective, and also kind of discussing the importance of physical therapy, getting workup appropriately with your primary care doctor and cardiologist. We'll understand the complexities of walking, and there's a lot of research that's gone on about how balance and gait is related to the cognition in Parkinson's disease. And we'll talk about therapies, and typically most of the therapies and discussions will be done through our question and answer towards the end. So please feel free to bring in questions as directed already. So most patients, when they come into our clinics, there's vague comments of unsteadiness, slowness, dizziness, and these are all utilized sometimes related to gait and balance. We want to understand why patients fall or feel unsteady, but the moment we start hearing about dizziness and lightheadedness, we presume there may be a combination of how the eyes and ears coordinate with our brain, how our eyes, ears, and then central nervous system affects our immediate balance of our legs and reaction times. So these are the type of things that we look for. And the dizziness that most patients with Parkinson's state when they come into our clinics is usually like a feeling of unsteady, like they're rocking on a boat. And that gives us an idea that there's an off-centered issue of their center of gravity and their balance upon standing. So these are situations that when we're looking for our answers, we want to be more specific. The questions have to be, when are we having balance issues? What is the determining factors? And that's when we ask, is it happening when you're getting in and out of a chair? Is it when you're taking quick turns? Is it through a doorway? We want to ask certain aspects of speed of walking. Are you going slow when you're having imbalance, or is it when you're walking fast? Do you notice that you're better going up steps or down steps? These are, again, situations that we do see that sometimes patients are better in different gradations. Certain surfaces are better for patients and maybe worse on others. We want to understand by family members about the length of steps that patients take, the width separated by the feet. And there's initiation factors where patients first try to get out of the chair and they may take short steps. We call it festination. And then patients may speed up where they can't control their legs. So the details of the environment are so key. Do people feel imbalanced or that dizziness when they are lying down as well? Or is it just when they stand on their 2 feet? Does it occur when they're sitting in a chair? And does that become more unsteadiness or balance in a stationary position when trying to turn? So we want to understand, is that dizziness or unbalance also when we sit? Because there may be other factors like tremors that can make us feel shaky and imbalanced even when we're sitting. Sometimes we have patients with no hand tremors, but only leg tremors. And when they're standing in one spot, their balance could be off because of the tremors that are signaled in their off state or when their meds are not working. Like I commented earlier, we've seen patients feel only imbalanced maybe when they're going up or down steps. The visual cues of the steps can also be misleading for people with Parkinson's. And we see with advancing disease of Parkinson's that this visual spatial depth perception is off, and it can make people feel like they're almost in a dizzy state or in a vertiginous state. So we always want to ask, when people complain of imbalance, are you feeling lightheaded? Have you fainted? Is there weakness of certain muscles, or are you also experiencing any numbness or tingling? Unfortunately, when someone gets Parkinson's, they may also have other conditions like hypertension, diabetes, may have had a stroke or not. And such things like diabetes may also cause already some numbness, which adds to this delayed perception of the feet on the ground and different steps. And that, again, affects balance significantly. So we want to always understand one's medical history. Some surgeries may affect people as well. If they've had lumbar surgeries, back pain that's caused by a disc bulge. They may be chronic history of nerve damage at the back that again affects the sensory and motor symptoms or motor fibers of the legs. So again, the clinical history is so valuable for us. And for a movement disorder specialist, we really want to understand medications, especially those that lower blood pressure. With Parkinson's disease, we see a lot of abnormal, erratic blood pressures. Sometimes it's low, sometimes it's high. It can happen when someone's just sitting down and there's a lot of lability with blood pressures. And then that happens as well with standing for patients. But we've seen in patients with taking certain Parkinson's medicines that also upon standing, the blood pressure drops significantly, which creates this gait imbalance factor. So gait disturbances, walking instability affects, we know, all aspects of life. And our concern is, can we avoid the serious injuries? Can we prevent the long-term disabilities that can lead to loss of independence? We want quality of life to be as strong as possible, as good as can be, and we want to avoid the institutional circumstances that come with consequences of falls. We also know that there's a significant burden with cost to the healthcare system based on needing helpers, nighttime caregivers, extra physical therapy, occupational therapy, and unfortunately, with these falls that can lead to bleeds in the brain or fractures and then secondary surgeries, there's higher rates of mortality. What we've seen in a large population-based study, that there's prevalence of balance issues, gait abnormalities. In patients 70 years and older, it was about 35%. And as we get older with age, 46% of patients can reported balance issues 85 and older. Now, this is again a circumstance where 50% of people 85 and older are at risk of falling because they feel unsteady. And we need to understand that with walking, especially with Parkinson's, we always think of walking as a motor task, but I want to teach upon you today that it's not just a basic reflex. It's not that we knew how to walk when we were born. We learned how to walk. And we learned how to walk slowly, and we had this development of our central nervous system, around 6 months to 9 months of age. And when we are dealing with Parkinson's, we end up having a deterioration or breakdown of these same pathways that we've learned when we were children or babies. And this aspects of these fine cortical processing centers, sensory centers, motor centers, we lose that with Parkinson's as it's progressing. So I want you to understand it's a very complex system that we have, and the aspects of walking kind of starts like a locomotion. We start off slow with Parkinson's. We may have to build up speed and then we can walk better. But what we do know with age, without Parkinson's and with Parkinson's, there is a reduction of gait velocity. Our stride length is also reduced by 20%. The characteristics of aging, as we see, is commonly aging changes our stance. So we have an increased width in how we stand. There's increased time spent in what's called double support phase, where both feet are on the ground. So when we're taking steps and trying to push off, maybe we have a reduction in the swing phase of our legs from right leg to left leg. We have also a bent posture. We've also know that there's less vigorous force with each push off, which again leads to less height of our step, and we can catch ourselves on, an uneven surface, a curb. So it's again very important to understand these characteristics. With Parkinson's, a lot of the physical therapies have been based on talking about big and loud. And one of the aspects of big is big steps, large exaggerated movements. And this is something we have to combat with the characteristics of aging and walking. So with patients who have Parkinson's and a flexed posture, their center of gravity is much more forward. And we have to be able to adjust for that when we're changing positions from sitting to standing or laying down flat to sitting up and then trying to get up from a chair or bed. the center of gravity is much more forward, and that's where we can have an instability of our legs not being able to catch up to our flexed posture. I wanted to show you some studies that have gone on for many years, and even the last 20 years, there's been a better understanding of walking in balance. But one of the aspects that is important is dual task performances in patients with Parkinson's and not with Parkinson's. So in healthy subjects, which means those without Parkinson's, for instance, if you're trying to carry something, or you're carrying grocery bags in both hands and walking, maybe talking on the phone, being distracted and walking, those are dual tasks. Walking is one task, and then whatever you're doing with your hands or talking with someone is the second task. Studies have been shown that even in healthy people, that motor errors were related to the complexity of the dual task. So, for instance, if someone was walking and counting backwards, we see a variability in one's walking. There's a reduction in one's speed and steppage. If someone's, for instance, being distracted with talking with someone on the phone, maybe it's dark, so we have to look at visual cues, and maybe our hands are out more. Those are concerns that we have with dual tasking. So we know with healthy subjects that when they're trying to recite alphabet backwards or spell words in reverse, there is continuous evidence that the walking speed and balance and sway is variable and worse. So this is, again, with healthy subjects with dual task. When we look at patients who have dual task with memory issues, for instance, Alzheimer's or mild cognitive impairment, we see that the more severe cognitive impairment, the worse it affects balance. So here are a few studies that showed that when patients with a decline in their thinking were doing dual tasks, again, either spelling, reading something, subtracting numbers from 100, there was, again, much more variability, further reduction in speed of walking. And again, this is much more determined that the worse the memory, the worse the balance issues and higher risk of falls. And this is based on different assessments of balance and gait. So with dual task processing in Parkinson's, what we know is that patients display already a greater amount of gait asymmetry. One side's always more affected in Parkinson's based on tremor, stiffness, and slowness. That stiffness and slowness, again, asymmetric on one side more than the other. So one leg could be not stepping as properly, forcefully, quickly. And we know that there's a reduction in bilateral coordination based on the studies. We know that there's increased variability when patients with Parkinson's do dual tasks. So the more we're distracted, the more variability we see with that leg that's slower, stiffer, and less reactive. And this was compared with age-matched controls during the same dual task conditions. So typically with Parkinson's disease, we already have a reduced speed, and that affects our reaction times. So with the dual task and cognitive processing, or the demands of what we're thinking about, really affect patients. I see many times when my patients are walking down the hall, when I'm examining their gait and they get distracted and look into a different doorway, they start shuffling their feet. Again, goes to the aspect of just being distracted as a dual task. And we've seen this in numerous clinical studies, whether they're retrospective studies. And we go into, there's been a discussion about what's called wrong prioritization, which means you need to, when you're walking, you need to focus on walking. When you need to start talking, you stop walking, and then you have that discussion. So we want to have the priority of walking only. If you're using a cane or walker, you utilize that carefully, what is most ideal based on the physical therapy assessments, but maybe not to also use something that's too complex. So it may be certain walkers aren't as good for us, and trying to prioritize our steppage may be distracted by the holding on to the walker that's maybe not appropriate. Some walkers may be better than others. Maybe some canes may be better than others, or some walking sticks may be more appropriate. So we've seen that even if you are utilizing some aid, it has to be, you have to still prioritize and make sure that you're coordinating your legs in an appropriate fashion. Some people talk out loud and state right, left, or 1, 2. Some of our physical therapists teach our patients to say heel, toe, and that helps with, again, prioritizing each step. But we do see that patients with Parkinson's who have intact cognition, they are better in their ability to take better steps, similar to healthy adults without Parkinson's. However, as we age with Parkinson's and we see cognitive decline, it's far more difficult to take proper steps, and we see more freezing of gait. There's been studies that show that if there's a decline in verbal fluency, there's higher rates of this disability, and sometimes we see this verbal fluency tested on neuropsych testing. What further makes it complicated is if we have white matter disease, which is what you see on the left of the brain scans. When you see mild to moderate and severe amount of white matter disease, the white color, the bright areas, that also adds to instability of walking. These certain areas and pathways affect steppage, and we believe that there's a subtype called postural instability gait difficulty in Parkinson's, whereas others may be tremor predominant. There's a specific also affected areas of the brain that makes someone have characteristics of this PIGD subtype. When we look at the white matter decline based on injury, there's also sometimes a cognitive impairment as well. There's also atrophy in certain areas of the brain, which means a reduction of the size. And there's been data that show that those who have more freezing of gait or difficulty with dual task performances, there may be a reduction in certain areas of the brain. And as we see with that arrow pointing on the far right, the corpus callosum, there's some atrophy or reduction in size versus someone who's healthy and more of a thick, robust size. There are, again, more disturbances of gait and balance. So reaction times are sometimes slowed, and those signals that occur from the brain down the spinal cord to the legs and back up, again, those signals are delayed, which again worsens one's gait. So medical conditions that again affect balance in Parkinson's, we don't want to underestimate hyper or hypothyroidism. There's heart conditions that, again, if we have an irregular heartbeat, if we have slow heartbeats that require maybe a pacemaker, we know other neurological conditions may affect patients' balance, including B12 deficiencies. If you already have had a stroke or have musculoskeletal weakness, that also affects our patients. With walking, if you have gout, make sure that's treated. If you have spinal stenosis, that can worsen one's balance with Parkinson's. And as we see bone issues, including osteoarthritis, that can be affecting our low back pain at the knees, again, will affect our balance. We know that someone who just maybe had new medicines for an infection and they're maybe confused, that will increase the risk of imbalance, so delirium. If you're having low sodium levels, low glucose, this again adds to coordination issues. If there's been spinal cord injury, that can also affect how our balance is and our reaction time. Muscles may be more rigid and stiff, affecting our Parkinson's as well. And I don't want to underestimate vision impairment. Please check with the optometrist or ophthalmologist at least once a year to monitor for such situations of nighttime imbalance. Now, the neurological exam is very important, where when a patient comes in, we want to assess their thinking, their processing. We need to understand as well if they've had issues with their vestibular, their hearing and eye pathways. Sometimes we do see that maybe someone has vertigo, they have something called nystagmus, maybe medications are affecting their ear, eyes, coordination, and there's certain areas of the brain that can be affected by certain meds, maybe certain blood pressure medications as well. We want to be able to check that there's good blood flow from the carotid arteries that are, again, we need to have good blood flow to the brain in all aspects. And if we see low blood flow, then higher risk of falls as well. If there are heart conditions, that allows us to be very particular in making sure we do the right referrals. It's kind of like if we have back issues, we want to see the orthopedist appropriately. And these are different tests that we do as neurologists. We look for vision, we look for strength and power, make sure there's no fatigability. A lot of imbalance with Parkinson's gets worse as the day goes on. There's, again, a lot of fatigability in the legs of patients with Parkinson's. We see that posture gets worse as the day goes on. And we need to look for sensory abnormalities that may affect gait as well. There's certain tests that we do with finger to nose testing to make sure certain aspects of the brain, like the cerebellum, are intact. And we do see that that may be a sign of maybe a vitamin E deficiency. So our examination involves quite comprehensive head to toe visualization. We want to see how people are standing, whether they're with their eyes open or closed. We test their cadence, their speed walking down the hallway, sometimes even by distracting them and telling them the days of the week backwards. We want to understand steppage, how they turn, how they stop, how their arm swings. And again, we've also seen where balance is really much affected with how your hands are. So we see a lot more imbalance with hands in the pocket. Keep your hands out, swing them freely and appropriately side to side. And that allows also to improve balance where you have better sway. We do certain tests, again, to look at the stance, swing phases, and making sure that our patients are putting pressure on their feet and pushing off accordingly. And again, we want to understand posture. Again, if we're much more flexed, we're going to have what's called fascination and short steps, short, fast steps that lead us to falling. When a patient's coming into our clinic, again, we're going to look for certain blood tests. If we see some sensory abnormalities like B12, we want to get neuroimaging. And again, hopefully today you're comfortable understanding that you have to be proactive about balance and reducing risk of falls. And sometimes, you know, some doctors may be late on doing imaging of the brain. Again, ask the neurologist to maybe get an updated imaging in case there's a concern of imbalance from a fall, making sure there's no bleed or stroke. And we sometimes do certain testing on the cerebral spinal fluid, we call it CSF, in case there is a buildup of spinal fluid in the brain and the ventricles. So it's very important to be following with your cardiologist in case your heart's not pumping well. And we do certain tests, again, to make sure that we're stable. As we look for classifications of walking, please be mindful of when are these imbalances occurring? Is it happening all the time? Is this something that is episodic, that's unpredictable? And then it cues us as neurologists and movement specialists to determine what the cause could be. So with cognition and gait, hopefully we've understood that when there is a decline in our thinking, maybe forgetful with words, maybe forgetful with fluency of how we get words out from our mouth, we do see a correlation with freezing of gait. Some patients may have a visuospatial decline in cognition, and that again may affect how they will go through doorways, different surfaces, tight spaces, maybe closets. And so executive attention is also very important in walking. This is just a brief diagram kind of understanding how the brain and different pathways are involved. We're showing here dopamine pathways in the basal ganglia, which is what we know is reduced in Parkinson's. These pathways are affected by our emotional response. If we see a fire, our heart's going to beat fast. We're trying to get out away from the fire. It sends signals to the midbrain and it goes down to the spinal cord and sends signals to move our legs fast. Sometimes before our basal ganglia can even react voluntarily. We again, use volitional processing to tell ourselves, pick up our feet, swing your arms big. And again, this interactions with our basal ganglia. Sensory signals, of course, from our environment may affect us significantly, especially where we see a ball being thrown at us. Maybe a person with Parkinson's who looks slow may be able to catch a ball very quickly if it's coming their direction. Our reflexes may be quite good with Parkinson's, even if we look slow. Maybe if a book is falling, we can quickly react. And then again, the cerebellum has different pathways that we see with the basal ganglia and how we get sensory feedback and make smooth, coordinated movements, whether it's with our hands or feet. And that's, again, affects balance significantly, as we see as all these pathways work our way down to the spinal cord to the legs. So this is a way of looking at cognition and volitional response, where you think of something as you're processing the illicit movement. We send signals from the higher level cortical regions down to the spinal cord to the muscles, and then we're able to run quickly. And we, again, as we think about it and we do it, like, again, picking up our feet, right, left, we can do this as a cognitive volitional process. So a lot of different processes go on. We know if we have strokes to certain areas of our brain, that will affect our balance as well. The frontal areas of our brain affect initiation of gaits. We know that if we affect primary motor centers or secondary motor centers, that will, or certain planning centers of our brain, pre-planning centers, that also affects freezing of gait and getting started. So there's motor strip and sensory strip, but certain areas before we send a signal to the areas of the brain that make movement, the pre-planning areas could be reduced in size. And if there's reduction in the size of these areas, whether it's from injury, trauma, degeneration from Parkinson's or Alzheimer's, we do see that that pre-planning areas affect how we take steps appropriately. So in emotional response, we call it flight or fight reactions. These are projections of areas in the brain called the Limbic Center and the hypothalamus that send signals and may bypass actually our basal ganglia. And sometimes with music, listening to things that are upbeat, we may be able to get better steps, better rhythm, improve our cadence, which again may help us. So if we think about something that is scary, we may have an emotional response, react a certain way, and that hyper aspect will make us fight or flight and run. So emotional responses can be uplifting, they can be shocking, but they kind of jar the system. So first and foremost, prevention, get a home health safety, be very cautious with what's around, grab bars in the bathroom, be mindful of keeping spaces open. If there's coffee tables all around that need to be maybe moved aside so you can have more of an open space, we can reduce the risk of shuffling of gait. Wear appropriate footwear, avoid sandals if you already are shuffling your feet. We want to, again, see the physical therapy upon onset of imbalance. If you feel like you're weak, fatiguing, need evaluation with assistive device, physical therapy is highly important. If there's cognitive decline, there have been studies that have shown starting certain medicines to boost alertness and cognition may help freezing of gait. And again, it's very individualized with what medicines may work or help. There are, again, Parkinson's medicines that we have to adjust, make sure that maybe we're more continuous in our dosing, make sure we're not missing medicines, and keeping very regular. The compliance of taking carbidopa, levodopa, or certain dopamine therapies is so important that when the medicine is wearing off, maybe we're more at risk of falling. So we want to be mindful that how the timing of our meds affects our day-to-day rotation, turning, twisting, and that's key. And again, if there is any vitamin deficiencies, nerve issues, have that corrected properly. With walking, you can do this at home, but work on your hip flexors, lifting up one leg at a time. You can do this sitting down, maybe having an extra weight. Physical therapists do a good job of working on strengthening those hip flexors. If there's anything you can do is work on your abs and hip flexors. Also, the extension of the knee is important. And, you know, the knee flexion can also be very important because it helps with pushing off. So if we can strengthen around the knee and really focus individual muscles, that really helps with balance and instability. And as we know with Parkinson's, most of the imbalance occurs one side more than the other. As we walk longer, our toes and our push-offs get weaker. So really focusing on foot flexion is another aspect of therapy. Individualizing here, as we see with bands, the plantar flexion of the foot, again, working individually one at a time, and the dorsiflexion of the toes, again, very important. So there's extension and dorsiflexion, which is important. So again, from a conclusion of understanding, see your neurologist for balance issues. Hopefully a movement disorder specialist can be of utility. If it's Parkinson's related, make sure you see regularly your cardiologist, ear, nose, and throat in case there's some ear, tinnitus, hearing issues, or loss of hearing that may affect balance. Check your eyes with your appropriate ophthalmologist. And as we know, walking can affect all aspects of life. Be very candid with your neurologist about how your balance is so we can act upon it sooner than later. We need to do a thorough evaluation, follow up appropriately with physical therapy and occupational therapy. And if there's any memory issues, the caregivers need to be definitely much more aware of this, that how it can affect balance. I hope that was engaging. I'm going to stop sharing and we're going to go to a point of questions. Cindy, I don't know if you need to delegate how we're going to do the questions. Evidente is going to start with some questions.
Yeah.
Dr. Evidente, are you going to join us now?
Yes, I am.
Thank
Yes,
you.
MD, that was really outstanding. Do you hear me?
Yes.
Okay, wonderful. That was really outstanding. That was really comprehensive. You know, I'm quite impressed with your discussion on the GAIT parameters. Do you actually use like a Xenomat or some kinematic GAIT analysis software or map to analyze the GAIT characteristics so that you're able to really know what's wrong with our GAIT, or whether the GAIT is just because of their age and orthopedic issues?
Yeah, so there's different therapies that I used to use. There used to be a GAIT lab I used to work with very closely, and unfortunately with COVID, they've had to close down. So there are certain GAIT labs that exist that are focused on such details of sway, positional, postural. A lot of our physical therapists utilize certain machines as well, and they give analysis based on timing, based on pressure, maps of the feet. I get some clues and tips from that. I usually depend on the physical therapist to work on those details. And right now with practice, we haven't been able to utilize as much of those GAIT analysis, but it is quite helpful, especially when we start a medicine, or even, as you know, Dr. Evidente, with deep brain stimulation, how that may affect balance. In case we're worsening balance, we want to know what programs or stimulation parameters help.
And with patients that have undergone DBS, are you impressed with any differences between STM versus GPI for balance or freezing of gait?
Both can be beneficial based on certain situations. So I was trained at UCLA, which is a very big center on DBS, but they were very pro GPI, globus pallidus, which is an area for our audience that is much more away from the midline centers, away from the spinal canal and signals, whereas the subthalamic nucleus is a lot closer and medial of a structure. So if there was sometimes signals that are to the globus pallidus that we send, there's less potential side effects with over-signaling and overstimulation, whereas with the subthalamic nucleus, maybe we would get too much stimulation to help control a tremor, that maybe we would affect parameters of speech or balance. Now, the key thing is if someone's very stiff or rigid, deep brain stimulation does a wonderful job, whether it's STN or GPI, to reduce that stiffness. And we can actually program in certain ways where speed can be improved. And so there are some times where we overstimulate one side, maybe like the right brain, to control the left foot very carefully by signaling it much more. And how we signal it, maybe a certain amount of voltage with a very low frequency. And there's other parameters, as we know, to maybe lower the pulse width, which is, again, a certain type of signal that's not too intrusive.
Okay, we have some questions from the audience. The first question is, I am surprised to hear only 35% number for GAIT survey. And was the morbidity increase only due to secondary events?
Yeah, and again, these are data that was done by, I think, the American Academy of Family Practitioners, but the mortality rates are, again, usually secondary measures, again, from the complications of fall that included bleeds, surgical complications, but again, related to hospitalizations from Parkinson's phenomenon.
And then a follow-up question to that is, please expand a bit more on CSF tests and what measures.
Yeah, so we do MRIs to look at the structures of the brain, but also there's certain cavities that we see called the ventricles of the brain. And those ventricles, certain areas can be actually enlarged. And as they enlarge, they put pressure on the white matter of the brain as well as the gray matter, and it pushes the brain centers really against each other. So if we think about a room that we're in and we're blowing up a balloon and blowing it up and blowing it up and blowing it up, it will cause, space surrounding to be pushed against the walls. So same thing goes with the ventricles. If they're enlarged, it can cause some irritation to the brain centers for walking and balance and even thinking. And there's a mimicker of Parkinson's called normal pressure hydrocephalus, which again will affect balance, thinking, and even urinary control. So sometimes we do what's called a lumbar puncture to measure the pressure of the cerebral spinal fluid. And if it's elevated, it may be suggestive a cause of normal pressure hydrocephalus to a certain degree, even though we say normal pressure, which should come out, but we see patients sometimes walk better right after taking out extra cerebral spinal fluid, and they may require something called a VP shunt if that's the case.
Yeah, and I'm quite impressed over the 2 decades I've been in practice, or probably more, of the coexistence of both Parkinson's disease and NPH. And in fact, I've counted maybe at least a dozen cases in my practice now. And so whenever I see patients with prominent lower body Parkinsonism, they're wide-based, they have gait ataxia, their feet are not together, they're not really shuffling, they're more ataxic more than anything else. Mm-hmm. And if imbalance is a very prominent issue from the get-go, and that's when I kind of suspect, especially as you mentioned, they start having some urinary urgency, and then later on incontinence, and even later on some cognitive issues. That's when I start suspecting that maybe NPH might be in play. I also suspect NPH when a patient is referred to me for Parkinson's as mainly lower body Parkinsonism, no tremors, put on levodopa, and absolutely no response to levodopa, and their main concern is balance and falls. So I guess my follow-up question to you is, how frequently do you ask for brain MRIs in your patients that are referred to you for Parkinson's?
I would probably say that we also do CT scans as well, and if there's been specific concerns of newly diagnosed Parkinson's or something like normal pressure hydrocephalus, I typically would go to some more detailed MRI. Predominance is most patients would have some imaging already done. If not, I would like to at least get some baseline imaging. I would like to make sure that even if they have Parkinson's that looks like it's idiopathic, coming about as a slow progressive disease, as a majority case here. I want to make sure there's no mimickers of Parkinson's, like a stroke, a bleed. We see these situations where, in very rare situations, but they do occur, and we don't want to miss something that could be maybe treated, or it gives us an idea as to understanding why medicines are working or not working. I don't typically get a DAT scan necessarily, but I do focus on getting some form of imaging at least once at the beginning of a diagnosis. And then if there's major changes in walking or balance or numerous falls, I want to make sure there's not a bleed that has curtailed or occurred.
Yeah. Okay. Another question from the audience. What do you mean about blood pressure can fluctuate with Parkinson's? Can that be controlled, or is that the new normal?
Oh, wow. I mean, I'm sure most movement disorder specialists are now, they should get a second degree in being a cardiologist, because we focus so much on blood pressure. In Parkinson's, we see such erratic highs and lows. I mean, a patient could be sitting and I can check the blood pressure, and it can go it can be 110/70, and it can shoot up to 170/60 without, much time being passed, and they're just still sitting there. I've had patients who are sitting down and they're 160/40, and then they stand up and it drops to 70/30. There's such erratic drops of blood pressure and also erratic highs of blood pressure, and there's some system that's not working that is checks and balances to the highs and lows of these erratic blood pressure. So we as neurologists utilize some medicines to make sure the blood pressures don't drop too much. We have therapies that are there to keep blood pressure at a certain level, and we have to be cautious that the blood pressures don't go too high. But most of the time we reduce some patients' blood pressure pills that they're already on that controls their hypertension, so we can try to avoid the bottoming out.
Yeah, and there have been studies that have shown that even in the so-called premotor stage of Parkinson's, for synucleinopathies like Parkinson's disease or multiple system atrophy or dementia with Lewy bodies, that if you were to do formal autonomic testing, many of these patients actually have some autonomic abnormalities, and orthostatic hypotension, which is what you just described very eloquently, which is a drop in blood pressure from lying to standing, and the cutoff usually is about 20 millimeters mercury of the systolic blood pressure. Many of our patients actually, even in the early stages of a Parkinson's syndrome, or even the premotor stage, may have some form of autonomic neuropathy. It can predispose them to these orthostatic symptoms. But again, I think many patients also are asymptomatic. Like, I'm really impressed at how many of my patients with high blood pressure, with Parkinson's, and then we take their orthostatic blood pressures here. We're not sure whether it's a blood pressure pill that's doing that or the underlying autonomic neuropathy. They have 30 or 40 point drops in their blood pressures, and yet they're not dizzy at all. Yeah. So I guess a follow-up question to you is, do you treat automatically these drops in blood pressure, or do you wait till they're symptomatic, or what do you do?
Yeah, that's a very good question. So again, I'm talking to Foundation of Arizona. So you guys, as well as California, we deal with droughts, right? We deal with heat waves. So one of the biggest drops and causes for low blood pressure or autonomics is lack of hydration or dehydration, and that's something that if we're seeing drops of more than 10 millimeters mercury with the systolic top blood pressure, I definitely even start, educating about how to be either liberal with salt, maybe adjusting medications. Even if they're asymptomatic, I always want to make sure I'm asking about, are you feeling dizzy, or asking about this unsteadiness. Sometimes patients may, bring it out once you kind of really are asking such situations of like, when you bend over to pick up something, and when you get up, do you feel kind of woozy? Like in those circumstances, I will, just be mindful of not necessarily with medicines, but just, good habits. I typically would only start treating if they're becoming more symptomatic, or if I'm seeing that there are falls unexplained, then we typically go after that if there's objective measures.
Oh, yeah, absolutely. I echo that 100%. And especially here in Arizona, where we have dry heat, and many patients actually get dehydrated. They think they're drinking enough fluids when in fact they're actually perspiring the fluid, all the fluids away, and therefore they get dehydrated despite taking, the so-called recommended amounts of fluid. So I guess the first aid measure, or the first thing I ask them first is, how much fluids do you drink? And also I try to make them, add some salt if the fluid hydration is not sufficient. Now, what about B12 deficiency? You mentioned in your talk the importance of the relationship of B12 deficiency and gait abnormalities. Do you feel like this is something we should be measuring routinely in our Parkinson's patients?
Yeah, one of the things that we learned is in training, as in neurology training specifically, was a test where you have a patient stand, and we call it the Rombergs for those who aren't aware of it, but it's you stand and then you close your eyes and then you see if there's an imbalance. That's one of the tests that if someone is unsteady significantly when they close their eyes, then I will definitely look for a B12 deficiency, and that's one of the hallmarks of it. If someone tells me, when I ask on the exam their social history, if they have any special diets and they say they're vegetarian, I typically would check for B12 deficiency. And anyone who comes in with for a consultation that says, hey, I'm having balance issues, I will check for B12 and other types of associated minerals like homocysteine and methylmalonic acid. And there's certain tests that we would do to look for that. But I wouldn't say I would do it every single patient. But one thing is that we do see, even like vitamin D. Vitamin D is there's a lot of vitamin D deficiency out there. And I see that much more in the general population and even our Parkinson's patients, but that may not affect balance as much as something like B12. Actually, today of all days in the morning, I found someone who had a B12 that was extremely low, and her main complaint was memory issues and balance. So can't wait to see how she responds with high dosing B12. Typically, we could do injections or ask them to take sublingual supplements, but that is something that is quite important in addressing.
Yeah, a couple of important points that you mentioned that resonate to me pretty loudly. The first is you mentioned methylmalonic acid and homocysteine. So I think the take-home message is that a normalish or low normal B12 can actually not be normal, and that one of the things that Dr. Thakkar mentioned is taking the methylmalonic acid and homocysteine levels, which increase when you're not absorbing the B12 and the B12 is not making it to your tissue. So if we really strongly suspect, especially if you have a neuropathy, you're falling, you have imbalance, you have numbness of your feet, and so on and so forth, you have some cognitive issues, then despite the so-called normal B12, I usually push for the methylmalonic acid and homocysteine levels to be measured. And homocysteine is elevated homocysteine levels have also been noted very frequently in Parkinson's patients without any B12 deficiency, because the metabolism of levodopa to dopamine depletes B12. And so, or should I say, leads to increased homocysteine, rather, leads to increased homocysteine levels. So one way to bring down that homocysteine is to give these patients B complex, including B6, B12, folic acid. And then another question from our audience: can you have Parkinson's and begin to exhibit some of the early signs and symptoms without a positive DAT scan? What do you think, Dr. Thakkar?
Sorry, the positive DAT scan, without a positive DAT scan and early symptoms.
Can you have Parkinson's disease?
Yes, yeah. I mean, look, I typically go with my clinical assessment. much more than the DAT scan. If the DAT scan is positive, then it's 99%. Yes, it's a Parkinsonism. But if it says negative, it could be incorrect 12% of the time, maybe a little bit less than that at time. But there's data that says it can be as incorrect with what we call a false negative for Parkinson's. And if the clinical suggestion is there with tremor, stiffness, slowness in a certain pattern, it doesn't mean that you have to right away treat, but you may follow up a patient for, again, after a month or two and just kind of see how they're progressing and see if their symptoms are still very similar to what you first saw. And, you really want to trust what you've been trained on. And like Dr. Evidente, you've had so many years of seeing a patient, you look at these other cues that not just a scan. We look at, is there a history of constipation? Is there sleep disturbances that are talking, yelling, or acting out dreams? Are there circumstances of reduced sense of smell, and even loss of smell, less likely than less of taste. And then, so again, constipation, we talked about loss of smell, the REM sleep disturbances. And I also look for like muscle cramps. Muscle cramps are one of those Charlie horses, are one of those pre-phenomena that I see a lot as well with Parkinson's. So I really trust my skill set of that. However, we've had some unique ability to either give a patient a medicine of levodopa, whether we crush it right then and there in the office. And I've actually used, Dr. Evidente, Inbrija, which is an inhaled form of levodopa, to get an assessment of, does the patient respond, whether it's with handwriting or fine dexterity or tremors, does that go away within 15 or 20 minutes after, while they're sitting in my office? And that kind of also gives me a clue more so than just worrying about a scan.
Yeah. Very well said. I just want to add that I like Dr. Thakkar, I've seen patients that I really strongly suspect have idiopathic Parkinson's disease that's levodopa responsive. He just alluded to using the inhalational form of levodopa to test a levodopa response. Although with the caveat that it's the duration of response, the enduring response of levodopa is a stronger predictor of Parkinson's disease than the immediate, one dose or testing levodopa for a few weeks. So the pathology studies, especially the more recent ones, have shown that even among patients that are levodopa responsive, in a movement disorder center, for instance, where Parkinson's disease is very frequently diagnosed, supposedly by very experienced specialists, movement disorder specialists and neurologists that see Parkinson's every day, the rate of misdiagnosis can be as much as 42%, and sometimes even larger within the first 5 years. So really the enduring response to levodopa, and they throw out a random number of about 5 years. So enduring response to levodopa of about 5 years with motor fluctuations, meaning on and offs, which usually develop anyway on an average 4 or 5 years from the start of levodopa treatment, as well as the so-called dyskinesias. So the enduring response, motor fluctuation, dyskinesias, most likely in a Parkinsonian patient will most likely represent Parkinson's. But I've also seen patients with DAT scans that have been misread, especially those that have asymmetric findings, or very subtle findings. Not every DAT scan is the same, or should I say not every DAT scanner is the same. There are some DAT scanners that are better than others. Also, there is a special software called NeuroQuant. So you can interpret DAT scans two ways. One is qualitatively and just looking at the images and saying, okay, the dopamine signal seems to be equal in both sides of the basal ganglia, or is it reduced in one side? Is it reduced in the caudate or the putamen, or both, and so on and so forth? That's qualitative. And then the quantitative, through a special software called NeuroQuant, actually measures the amount of dopamine signal in comparison to normal individuals. So I trust more the DAT scans with neuroquant data. But even so, the so-called normal DAT scans, if I really suspect that they truly have Parkinson's, and especially if I do a levodopa challenge, as you mentioned, I read the DAT scans myself, and I kind of say, okay, there's some asymmetry here. I think it's mildly reduced. And so I follow this patient like as if they had Parkinson's disease. And then they've also looked at these patients, they've taken a second look or even third look at these patients that initially had normal DAT scans. So there was a study, or even more than one study that's been published, where they took a second look at these patients, doing another DAT scan, maybe 1 or 2 or more years after. And true enough, a good percentage of these patients that were initially thought to be normal, but were thought to be clinically compatible with Parkinson's, converted to abnormal DAT scans. So the lesson is, if your doctor really feels that you have Parkinson's, you act like a duck, you walk like a duck, you quack like a duck, it must be a duck, regardless of whether the DAT scan is abnormal or not. Okay, some more questions here. I'm going to skip the question on REM behavior disorder, since I'm going to tackle that in the questions that were asked by the audience in the second part. Here's a question. Is there any relationship between essential tremor and foot neuropathy?
With essential tremor and foot neuropathy?
Are you aware of any?
You know, I mean, there's different types of you know, when I see certain dystonias, I actually see more neuropathy than essential tremor per se. But if there's a good amount of Parkinson's related tremor, then I would see more neuropathy as well, but not necessarily. I don't see specifically an essential tremor relationship typically with neuropathy.
I agree. Now there's a type of tremor called neuropathic tremor. So patients with bad neuropathy, CIDP, for instance, or one of these bad motor neuropathies with atrophy of muscles. Some of these patients can develop so-called neuropathic tremor, which looks like a crossbreed between essential tremor and a cerebellar tremor. Now, neuropathy can also occur in Parkinson's patients, obviously, and I think studies have shown that the chronic intake of levodopa can actually predispose to neuropathy, and this goes back to what Dr. Thakkar eloquently said in his talk about B12 deficiency, but they've also looked at folic acid deficiency in this population of patients, also B6 deficiency. Mm-hmm. Okay. Levodopa, how much can be used safely, and what causes it to be ineffective? What is the next step after levodopa?
Well, you know, the dosing is not necessarily what we can hang our hat on. Some people can barely tolerate half tablets 3 times a day, and some people require over 2,000 milligrams a day. So, you know, each person is very individualized based on their response on blood pressure, if they can tolerate it as far as nausea. But, you know, what I've seen, and with more continuous like therapy of levodopa, I see a better smoothness of their physical symptoms, including walking. And I've seen some freezing of gait improve in such select patients. Again, anecdotally, this is under, again, in my clinic, we have a lot of patients who've done something called the Duopa pump, and it's a continuous levodopa, which has allowed for a better stream of flow, and some people do better with less festination and less short steps. They're more on. So whatever we do as neurologists, we want to optimize the on time. We want to have patients get a good response with levodopa, but maybe some patients get a good on with also some dopamine agonists, some boosters to levodopa that are medicines called MAOB inhibitors. Or COMT inhibitors. So there are medicines that sustain or lengthen the effectiveness of levodopa. And there are also maybe medications that cognitively slow you down. I mean, some patients take a lot of sleep medications, and we try to avoid medicines that are downers or muscle relaxants that slow our brain down. So there are medicines that actually make us have less on time because they are negative to our alertness and focus. So again, those are type of things that we must look at, not just a quantitative number of levodopa. We look at what other medicines patients are taking. But I've seen even in situations where, historically people have said deep brain stimulation doesn't help gait, but there are times actually it can be quite useful. And again, it's more about what aspects of gait are affected, which is, again, if the stiffness is slowing down someone's balance, and like say the right leg doesn't just take good steps, you can with DBS reduce some of that tension and muscle tightness that allows a patient to have more free steppage. So again, that's one of the perspectives I have seen.
Yeah, and I echo that as well. And I think you do this routine yourself. We do on-off testing before DBS, give them the maximum doses of medicines that they take, or if I feel that they're underdosed, I give them a heftier dose in my office and levodopa challenge, and then see whether their balance or gait will improve. Whereas literature will say that DBS is not meant to improve gait or balance. The truth of the matter is, any motor off symptom that improves in the on state, it is only present in the off state, will most likely improve with DBS. So for instance, I've seen patients with imbalance only in the off state, and that improves with DBS. Or for instance, I've seen patients with freezing of gait only in the off state. The moment they're fully on with their levodopa, the freezing completely disappears. And those are the patients that do very well with DBS. Okay, we're gonna take a little break. I'm gonna pass the floor back to Cindy. She's gonna introduce